In the next video I'm going to show you the AC joint and also looking at the infraspinatus, teres minor and the dorsal glenohumeral joint. Patient is still seated upright, sitting on a stool, placing the transducer over the AC joint, connecting the clavicula with the acromial bone, like this. And what we will do is we're going to first check the AC joint statically, so sweeping the transducer from ventral to dorsal, looking at the bone regularity and also how the capsule thickness is and whether we see effusions. From a traumatic perspective, we can also look at joint width, the height of the clavicula in relation to the acromial bone, as if there is a huge difference, then it might indicate ligamentous injury. So after I've scanned it with the patient statically, then we're going to ask the patient to move dynamically by making a movement, a cross-arm maneuver, which is from this location to the other shoulder and then totally back. And at this location the patient needs to relax fully, and what we're going to assess is the stability of the AC joint. So do the two bones stay together? So let's do that by making this movement. Okay, so you can move your hand to the other shoulder. Right, good. And go back please to your leg, and at the end please fully relax. Okay, so we don't see any change in the bone, and that is a good thing, because with an instability you would have seen a large drop of the clavicula. Then we're going to check the infraspinatus tendon and teres minor. So we're going to rotate the model a little bit, and then I'm going to place the transducer on the insertion to the greater tubercle. And now we can see the insertion of the infraspinatus with on top of it the subacromial subdeltoid bursa, and we're going to slide the transducer to distals to also check the teres minor tendon. After we have checked this insertion, we're going to follow the tendons towards the humeral head and beyond to the musculotendinous junction right here, and even further to the posterior joint right there. Now we can see the glenohumeral capsule attached to the labrum, and that is attached to the glenoid cavity, which is the lowest bone seen in screen. Overlying is the infraspinatus muscle and the hyperechoic infraspinatus tendinous aponeurosis. So let's have a look at the external-internal rotation. We look at the movement of the labrum, how that one behaves, but also for fluid accumulation in the joint capsule in the posterior recess, and see whether the labrum stays in the same spot. After having checked the labrum and the joint, we all can move a little bit further to search for the sphenoglenoid notch. Now the deepest in screen, 4 centimeters of depth, and we're going to make an external rotation to see whether we can see fluid collections accumulated around the nerve, the suprascapular nerve, and screen for a nerve entrapment. Now we can see the vein opening and closing with making this external rotation, but that's a normal finding. If you see a fluid, then this anechoic mass stays there, whether you internally or externally rotate. Then once again going to the infraspinatus tendon insertion and following in transverse view the infraspinatus to the tendon to the muscle belly right here. Now we can see the infraspinatus muscle belly, and once again what we will do is check the infraspinatus muscle, search or assess the echogenicity, and we compare it with the overlying deltoid muscle, and this echogenicity should be fairly the same. You can see the internal aponeurosis very well, so this is also a sign of a healthy muscle, and we're going to ask the patient again for a contraction. So you can push there, yes, and relax. Once again, yes, and relax. Okay, so this is also a healthy muscle.